The Ottawa ankle rules. So radiographs are indicated for the ankle if there is tenderness along the posterior edge of the distal 6 centimeters of the lateral malleolus, if there's tenderness on the medial malleolus, and or the patient has an inability to bear weight for at least 4 steps. Radiographs are also indicated for the foot if there's tenderness over the navicular, if there's tenderness over the base of the 5th metatarsal, or if the patient has an inability to bear weight for at least 4 steps. The test item cluster for patients who will respond to spinal stabilization include an age greater than 40, aberrant motion, which is demonstrated by the patient bending forward and then coming back up, and we're looking for pain with that motion, an instability catch, reversal of lumbopelvic rhythm, or a pseudo-Gowers sign, which is thigh climbing as he comes back up, a straight leg raise, I'll have you lay down, of less than 91 degrees. Relax. Good. And a positive prone instability test. I'll have you come to the end of the table, stand there, turn around, and face this wall. I'm going to pump this up to right about your pelvis height. And I'll have you lean forward with your chest on the table. While he's here, I'm going to palpate his lumbar spine for any hypomobile segments. Once I find one, if there's pain there, I'll have him hold on to the end of the table and raise his legs up. I'll palpate the same segment again, and if the pain is diminished, it's a positive test. The test item cluster for patients who will respond to spinal manipulation are a duration of symptoms less than 16 days, no symptoms distal to the knee, an FABQ work subscale score of less than 19, one or more hypomobile segments in the lumbar spine, or hip internal rotation less than 25 degrees. McMurray's test. This test for meniscal pathology. The patient's knee will be maximally flexed, the tibia will be internally rotated, and the knee will be extended. An audible pop or click during this motion is a positive test. I'll be completing the Lockman's test for an anterior cruciate ligament pathology. The patient's knee should be flexed to 30 degrees. For a patient of this size, I'm going to put my knee underneath this thigh for some more support. I'm going to stabilize his femur with my right hand, and with my left hand, translate his tibia forward. A positive test is excessive laxity or a soft infeel. Anterior drawer test of the ankle. I'm going to stabilize the tibia and fibula, hold the patient's foot in 20 degrees of plantar flexion, draw the talus forward or anterior on the ankle mortise. A positive test is indicated by excessive laxity, and this is indicative of an injury to the talofibular ligament. This is the anterior drawer test. The patient's knee is flexed. Hands are placed on the joint line and behind the tibia to ensure that the hamstrings are relaxed. Tibia is drawn anteriorly. Positive test is noted with excessive motion. We'll be going over a differential diagnosis for glute and hamstring weakness versus an L5-S1 radiculopathy. For glute and hamstring weakness, there'll be weakness in hip extension, abduction, external rotation, and knee flexion. Reflexes and sensation should be normal, but they may have a positive Trendelenburg sign, which is indicated by a weak glute medius. For L5-S1 radiculopathy, the patient may experience numbness or tingling in the L5 and S1 dermatomal distribution. They may also have myotomal weakness in their plantar flexors and great toe extensors. There will be a decreased S1 reflex in many cases. There will also be a positive slump test, which was demonstrated earlier, and a positive straight leg raise, which was demonstrated earlier. But we will do the well leg test. That is the same as a straight leg, but you raise the non-symptomatic leg to see if there are any symptoms between 30 and 70 degrees. The patient may also have abnormal imaging.